Dr. Luke Laffin is the director for the Center for Blood Pressure Disorders in Cleveland Clinic. He is also our medical director for cardiac rehab, but more than anything else, he is the most expert in the hypertension world. He has conducted many different trials. He also is an authority in the world to write about secondary hypertension as well as the hypertension control. And he has been involved in many new different devices and trials treating hypertension. So as a clinical trialist, he's also very well recognized. So this is a great pleasure and honor to have him here to represent us and to present the hypertension in 2024 and beyond, because this is one of the most important topics for cardiology, internists, as well as people interested in healthcare policies. So Luke, it's wonderful to have you here.
All right, thank you very much for those kind words, Dr. Kapadia. So as he mentioned, I'm going to talk about hypertension in 2024 and beyond. So really the outline for today's talk is looking at where we are now and thinking about 5 to 6 years in advance about where we're going in terms of hypertension. So we'll start by talking about the state of hypertension control. We'll talk about current treatment approaches, just very, very briefly. And then hypertension is such a huge multidisciplinary topic that we could talk about all kinds of things. We could talk about emerging pharmacotherapies. We could talk about device-based management for hypertension, digital and AI strategies. We could talk about population-level strategies for blood pressure awareness and hypertension control. And those are conferences unto themselves that we could give. But what I really want to focus on, and one of my passions, is emerging pharmacotherapies for hypertension management. And so we'll talk about that. If you want more on sort of the bread and butter hypertension management, I'll do a little shameless plug here. Our Braunwald's book just came out, or my Braunwald's book came out, Hypertension. So you can happy to check that out. I have some extra copies if any of the fellows want it too. So we know hypertension is a big deal, okay? And we know that it's killing people, causing cardiovascular disease. This was a report put forward by the World Health Organization back in the fall of last year. And I like this graphic. And essentially, this is many countries throughout the world. And the different hashed lines there are percentages of patients with hypertension, how many are controlled, how many aren't. And if we look at the United States, it's a little bit of an outlier, particularly when you look at first world sort of developed countries, particularly Canada, okay? You know, we're approaching 40% of individuals with hypertension, and that's based on a 140/90 definition, not the more contemporary 130/80 definition. And a large percentage of those individuals are still uncontrolled. We also know that hypertension control is getting worse in the United States. If you look here, this is data from NHANES looking up from the early 2000s up through about 2018. Blood pressure or percentage of patients that were controlled was improving. And then we start to see a dip right around 2013, 2014. Not coincidentally, probably related to the JNC8 blood pressure guidelines, which really has put less stringent thresholds in terms of blood pressure management. And the question was, well, with more contemporary guidelines, the 2017 ones, would we see an improvement in levels? But unfortunately, the global pandemic happened, okay? And what we saw, and this is some data that Stan Hazen and I worked with Quest on, looking at their employee health wellness screening, is that month-over-month changes from 2019 to 2020, we can see that when March came in 2020, blood pressure on average for the U.S. population, this is not patients with hypertension, this is just your average person getting an employee wellness screening, increased pretty significantly, you know, anywhere between 1.5 to 2.5 millimeters of mercury systolic, which for an individual, not a big deal, but across a population, increases risk, strokes, heart attacks, et cetera. What we also saw was that no group was spared, okay? Men, women, young, old, all saw this increase when we look at that pandemic period, comparing April 2019 to 2020. all the way through the end of the year. And probably the biggest burden was on older women, okay? They saw almost a 3 millimeter mercury increase in systolic blood pressure. So the question is, well, what the heck do we do about it? The United States and the Surgeon General back in 2020 really put forth a national commitment to improve the care of patients with hypertension in the United States. And it had 3 stated goals. One was just to write this, declare it a national priority. 2 was to ensure there was community level supports and use them and encourage them, because we know as physicians we can't do this alone. We need pharmacists, et cetera, helping. And then 3 was really, how do we achieve optimal care for these individuals? Now, no Cleveland Clinic study or discussion on hypertension would be complete without this mosaic theory of hypertension proposed by Irving Page, who was at Cleveland Clinic many years ago. So this was originally published in 1949 in JAMA. And it essentially suggests that hypertension is multifactorial, and we all know that. Now, when we get up to speed, 2010s, 2020s, we know that it's much more complicated than that, particularly when we bring in the genetic side of things. And then what's actually happened is a more updated mosaic model of hypertension has been elucidated, looking at things like the microbiome, sympathetic activation, vascular and endothelial dysfunction, sodium storage and intake, and so they all play a role to make it complicated. It's not just one thing. We also know that, particularly in the United States, there's many people at the table in terms of treatment hypertension. It really depends where you are, okay? Primary care is obviously the front line, and they treat the vast majority of hypertension. But depending on where you are in the country, you could see a cardiologist, a nephrologist, an endocrinologist for your hypertension. You know, in academic centers, it's a little bit more nephrologist generally, but anywhere outside of that, it's just because cardiologists are so much, there's so many more of us, we tend to see it when we get into the community, et cetera. So what's the standard of care right now? All of us know it's the ACD combination. And then when that doesn't work, guidelines recommend that we add an MRA, so spironolactone and a eplerenone, and that's based on the Pathway 2 data. But is this good enough? And if you haven't caught on yet, no, it isn't, okay? This is updated circulation or statistics from NHANES from the most recent statistics published in Circulation. And so what we can see is that, you know, about 60%, 65% of people are aware that they have hypertension, about half are under treatment, but only a quarter are controlled when we look at that 130/80 definition. And that's irrespective of age or race in this scenario. You know, a little bit older, you tend to have a little bit better control, as you can see on the right side of the slide, but, you know, it's still only a third of individuals. So the question that we're going to talk about over the next 40 minutes or so is, can we move towards a more effective approach? And I'm going to propose a few different ways that we're going to do that, because there's a real renaissance in terms of hypertension, drug therapy, and how we treat it. So here, number one, this is a potential way to do it. So I'm going to show some numbers, 26 to 28%, and then 40%. Well, so these are statistics respectively from the Framingham Heart Study and the Nurses Health Study. And these are the percentage of hypertension cases attributable to excess body weight, so overweight and obesity. What about this number, 76%? Well, this is our resistant hypertension clinic patient population, okay, with body mass index over 25, okay? More than 3/4 of these individuals, and probably about half, have a body mass index over 30. And so we know that obesity contributes to hypertension. Now, I like to think about it in this way, because we know that not all patients with obesity have hypertension, but we do know that if you do have obesity, you are more likely to have it. And so if you look at the frequency on the y-axis here and the blood pressure on the x-axis, what we can see is that in lean individuals, some are going to have hypertension, but the majority probably are not. But as we develop obesity and have weight gain, what we see is that frequency and that distribution of blood pressure changes, okay? So so it shifts towards higher levels more than anything else. And by the time we're up in that, you know, body mass index 30, 35 plus, you know, the majority of those individuals will have hypertension. We also know that hypertension and obesity are very prevalent in the same areas of the country, okay? If we look, obviously the Southeast, in terms of all cardiovascular disease, we see it, and then we can see we're sort of right on the border of it in Cleveland here. But we're talking, you know, in some areas of the country, we're talking more than half the individuals have hypertension, and almost half those individuals are living with obesity as well. So, how does obesity increase blood pressure? Well, again, it's multifactorial. There's several mechanisms operating simultaneously. So there's sympathetic activation, okay? Especially that visceral adiposity that we see. We can see increased renal sodium reabsorption, release of renin. Also, leptin stimulates the sympathetic nervous system. We know natriuretic peptides decrease, okay? And we know that their concentration increases after any type of metabolic surgery. There's mechanisms associated with the renin-angiotensin-aldosterone system, which increase MR activity, aldosterone, et cetera. We know that in obesity, there's extracellular fluid volume expansion, increase in venous return and cardiac output, amongst others. Obviously, extra adiposity induces inflammation, insulin resistance, sleep apnea, et cetera, okay? So there's all kinds of things going on. Now, if we just tell patients to lose weight with lifestyle, what do we get in terms of blood pressure reduction? Well, there was a meta-analysis of 25 randomized control trials of non-pharmacological weight loss. And what we can tell patients is that if you lose a kilogram of your body weight, you get about 1 millimeter of mercury reduction, okay? So we're nothing to write home about there, but that's sort of what we know. Now, it doesn't mean we shouldn't tell individuals to exercise. We know that there's numerous beneficial effects, okay? Reduced inflammation, arterial stiffness, et cetera. But it's not a game changer when we think about obesity-associated hypertension. What about metabolic surgery and blood pressure? Well, it's not just weight loss, okay? We see blood pressure reduction in individuals with metabolic surgery as early as 1 week postoperatively. So there's multiple neuroendocrine mechanisms that are at play, okay? We get an increase in GLP-1, okay? Increase in circulating natriuretic peptides, like I talked about. Now, it's not completely understood, but we know it plays a role, okay? One of the most significant randomized clinical trials to look at this was the Gateway RCT. So it was gastric bypass to treat patients with obesity with hypertension. And so what it was you had to have a body mass index between 30 and 40 and be on 2 or more blood pressure medicines. And you were randomized to Roux-en-Y gastric bypass plus medical therapy or just medical therapy alone. Now, this was open label, okay? There was no sham bypass surgery. But the primary endpoint was, I thought was pretty clever, was a reduction in 30% of the total blood pressure medicines while maintaining a normal or controlled blood pressure at that time, 140/90. And so this is what they showed. So amongst those individuals that got medical therapy plus metabolic surgery, okay, 83, almost 84% of those individuals achieved that. Reduced their blood pressure medicines by 1/3 and got their blood pressure under control, whereas only 13% in the medical therapy achieved this. So very clearly a benefit from that. And then the panel on the right is interesting, I think, looking at the difference between baseline and at 12 months in terms of the distribution of medicines, okay? Patients got off medicines. We look, half of the patients that received gastric bypass were no longer on blood pressure lowering medicines, whereas medical therapy, the distribution was essentially the same, okay? They were on the same number of medicines. Now, we all know that obesity or the treatment of obesity as a chronic disease is just exploding in the United States. So the question is, well, what is the effect of these anti-obesity meds compared with placebo on blood pressure? And so there's a list of some of the more common ones historically that we've used, and you can see this impact is relatively modest, okay? Naltrexone bupropion actually increases blood pressure a little bit, but liraglutide, phentermine, topiramate, and orlistat, pretty modest decreases. What you can see on the far right is semaglutide, okay? And that's not an insignificant difference there, okay? We're talking 6/3 millimeter mercury change. If you look at the SELECT trial, where patients only got about a 9% total body weight loss, it was about 3 to 4 millimeters of mercury systolic. So again, in that ballpark as well. And the red here is how much body weight in these studies when they looked at how much they got, about 15%, okay? Well, what I think is exciting is also these combined GLP-1, GIP agonists and their impact on not only weight, but blood pressure as well. So, which tirzepatide is really the hallmark case of this. So these are some data from SURMOUNT-1, so the obesity study published in New England Journal about 2 years ago now, a year and a half or so actually. And this is from the supplement looking at blood pressure changes, okay? And these were patients who had relatively well-controlled blood pressure at baseline, okay? 123 systolic over 79 diastolic. And so what you can see at each of the doses, 5, 10, and 15, there was a significant decrease in blood pressure. We're talking 6 to 7 millimeters of mercury in this scenario. Now, what they also did was they did an ambulatory blood pressure monitoring subset. So 600 individuals, they had to have controlled blood pressure at baseline. And this was really done to look at heart rate as well, because we know that the GLP-1s and GIP agonists can increase heart rate a little bit. So ultimately, they had just under 500 with evaluable ABPM data, body mass index of 37. Now, these are some data that I think they're being published they are being published next week in hypertension that we looked at, and really the difference in terms of ambulatory blood pressure monitoring. And we see a pretty similar idea that we saw to the office blood pressure, okay? So with the doses of 5, 10, and 15 of tirzepatide, you see overall about anywhere between 8 and 11 millimeter mercury decrease in systolic blood pressure, a little bit less so in diastolic, as well as a pretty significant nighttime dipping, okay? We want, on average, blood pressure to go down 10 to 20% at night. That's normal. And so we saw a reduction here of 9 millimeters of mercury in the tirzepatide 10 milligram arm. What we also see is that this blood pressure reduction really didn't matter depending on a variety of statistics. If you're old, young, BMI 35 or less, or 35 or more, if they were on blood pressure medicines or not, you didn't really see a major difference there in terms of, so everyone seems to benefit from this. So as that first thought of could we be more effective is, could there be a role for upfront treatment of obesity, particularly in patients with stage 1 hypertension, right? Treat that cause up front. Don't just treat the blood pressure, treat everything else. And so I think we'll see in the future if there's a role for that. All right. Next, could we move towards another effective approach? All right. We know patients don't like to take their medicines. That's very clear from an adherence perspective from blood pressure. So what about using longer acting and effective medications? And really, hypertension with, treatment with siRNAs and antisense oligonucleotides, so those so-called RNA-based therapeutics, is really the next frontier when we think about this. So in cardiology, particularly preventive cardiology, we know that they're in use, okay? Many of us are now familiar with inclisiran and the Orion trials, okay? We know that these effect can last up to 6 months. So inclisiran is a short interfering RNA for LDL cholesterol, or lowering LDL cholesterol. It acts against PCSK9, and now we've been using it for a couple years. So what do we think about when we think about hypertension then? Well, what if we target very upstream of everything else, okay, that we've been using from pharmacotherapy to treat blood pressure, okay? So can we target really the first part of this pathway, which is angiotensinogen with RNA-based therapeutics, because it is the sole precursor of the potent vasoconstrictor angiotensin II, okay? And there are certain drugs under development that are looking at this, okay? The most discussed and most talked about at this point is zilebesiran, okay? It's being developed by Alnylam in combination with Roche. And so it's a GalNAc conjugated molecule, so it's directed towards the liver, and it knocks down angiotensinogens, specifically in the liver. What are the mechanistic advantages of something like this? Well, it's got a prolonged duration of action because it is GalNAc conjugated. Theoretically, it would provide a consistent and durable blood pressure response, okay? We're not getting the ups and downs of taking a pill every day or skipping it while we're on vacation, et cetera. You get your shot, you're done, okay? And so you get it in clinic and you're not worried about people taking their blood pressure. So they have a very robust development program, and some of the data has been published in New England Journal earlier this year. I want to talk about it because I think it's really the future and really interesting where they're going. One thing I will make note is that it's not actually, at least at this time, going to be developed as a pure hypertension drug, at least a hypertension label by the Food and Drug Administration. What the thought is to launch for cardiovascular risk reduction. And my assumption, I don't have any inside info here, is that that's just from a pricing perspective. The pricing from a hypertension drug is very different from a drug that reduces strokes, heart attacks, et cetera, in a large cardiovascular outcomes trial. And so it's expected to launch within about 5 to 6 years. But let's talk about their phase 1 study that was published earlier this year, looking at safety and tolerability in individuals with mild to moderate hypertension. So what we saw was a dose-finding study of zilebesiran. So it's a subcutaneous injection, okay? And looking out, the primary endpoint was just, does it reduce serum angiotensinogen? And the answer is yes, okay? They do. This was single dose. Simple, okay? But what we also showed was it pretty significantly decreased blood pressure, okay? This is looking at changes from baseline with the different doses, placebo, 200, 400, and 800. And you can see with that 800 milligram dose, you're looking at about a 17 millimeter of mercury decrease in blood pressure at week 8, okay? And all the way out to almost 23 millimeters of mercury at week 24 in this scenario, with really very minimal placebo effect here, okay? So that was just the dose-finding study, but it's a whole program of other things as well. So what was also described in that manuscript, and one of the concerns with a long-acting medicine is, well, what if we go too low? What happens? Okay, what if we get volume deplete? What happens? So one thing that they did here was they randomized patients to first undergoing a low-salt diet, then a high-salt diet, see what their blood pressure does, then give them placebo or zilebesiran at the 800 milligram dose, and then again, low salt diet versus high salt diet. Again, looking at the same endpoints, reduction in angiotensinogen, circulating angiotensinogen, and then blood pressure as well. So what you see is that, of course, yeah, it reduces angiotensinogen by almost 100%, okay, in the 95% plus range, okay? But this is what happened with blood pressure, okay? So if you start at the left side of that right panel, what you can see is without any medicines on board yet, blood pressure went down when you were on a low sodium diet, no kidding, okay? Then it went back up when you're on a high sodium diet. And then right in the middle there, they got zilebesiran or placebo, the siRNA. And you can see in the setting of the low sodium diet, the effect of zilebesiran was potentiated. So to a large extent, it was decreased, okay? But then if you said, okay, have some more salt, let's see what happens, that effect was diminished, okay? Suggesting that maybe if we just have patients have more salt, if they get hypotensive, it's gonna be relatively safe, okay? But still to be determined. You can see low numbers there. All right. The other question was, well, how is this going to work in combination with additional therapeutics? All right. So what they did here was they gave participants a dose of zilebesiran, 800, and then at the 41-day mark, I believe, so 6 weeks or so, if their blood pressure was still uncontrolled, greater than 120 millimeters of mercury, then they received an ARB as well for 14 days. And then they got an additional 24-hour ambulatory blood pressure monitoring. And so what you saw here is that those patients that only received zilebesiran, they had a very robust response, right, as we would expect, because they didn't ultimately get the ARB, okay? But when you ultimately added on the ARB, you got essentially double the reduction. So it's a little bit of a synergistic effect there. You went from 7 millimeters of mercury down to 14 millimeter mercury decrease from baseline in terms of blood pressure. So it can be potentially beneficial in these groups, okay? So that was their phase 1. Phase 2, the first of the phase 2 was presented at AHA in November this year, looking at a little bit, well, much larger patient populations and looking at a little bit different dosing as well. So they all reduced serum angiotensinogen, okay, to a large extent. We're talking 90+%. They also reduced blood pressure significantly. They looked at 3 months, 6 months, et cetera. At the 6 month, it was pretty similar to what I showed, about 14 millimeters of mercury placebo-subtracted blood pressure control or reduction. You can see the placebo group went up here a little bit, which is a little bit strange for 24-hour ambulatory blood pressure monitoring. It usually should be about no change, but you're in that 10 to 15 range, so it's in the same ballpark. Okay, but I think the most important thing is this, and this is from the supplement from the New England Journal paper, is looking a very consistent relationship between if you lower serum angiotensinogen with some RNA-based therapeutic, you're going to get this reduction in blood pressure, okay? And so that brings us to talking about what about antisense oligonucleotides as well. And so there's really two that have been studied. One is just a modified version of the other. So this Ionis AGT-L was a GalNAc modified ASO given subcutaneous weekly, okay? It reduced angiotensinogen, not as much as zilebesiran, more in the 75 to 80% range, but it was a weekly injection, okay? And I don't think anyone's gonna give a weekly injection compared to a 6 month, okay? So, and what they showed was the blood pressure effects were modest. This is small numbers. This is a waterfall plot looking, and there's more patients with significant blood pressure reduction. We're talking 25 to 30. So this was published now about 3 years ago or so. So what they ultimately developed was this ION 904, which is GalNAc conjugated, a more potent ASO, okay? And they presented this data at AHA in November. Phase 2 study looking at patients on at least one blood pressure medicine and some different doses. And what they saw was a mean percent reduction in angiotensinogen levels right around 80 to 85%, okay, at week 15. So where does that put us? Well, that puts us probably in about the 9 to 10 millimeters of mercury blood pressure range, and that's sort of what you need, okay, to make a viable case for a blood pressure medicine nowadays, given the competition and obviously the availability of generics in that scenario. And this is a once a month injection as well, which people are probably a little bit more, I would argue, maybe even a little bit more excited for, because if you do get septic, if you have a GI bleed, if you had a bad reaction, it's not sticking around for 6+ months. So to be determined. I think that you could go both ways here on the spectrum. All right, once, as I said, maybe once a month is better than 6 months when we think about safety, particularly from a patient perspective. But then maybe we go complete other way, okay? What if we do gene editing, okay, in terms of angiotensinogen and knock that down in the liver? And they've done that in animal models, now published a couple years ago. So to be determined, but I think angiotensinogen as a target is clearly where we're heading in terms of blood pressure, longer acting medicines, not that daily pill. Okay, now, also, can we move towards a more effective approach? One thing that we know is that what has been grossly underdiagnosed in hypertension for years and years and years is primary aldosteronism, okay? We do not, not just cardiologists, we're talking nephrologists, primary care doctors, endocrinologists. There's been a lack of appreciation for how much aldosterone contributes to hypertension. And we're not just talking your clear-cut primary aldosteronism, clear secondary cause of hypertension. We're talking about also autonomous aldosterone production leading to not quite meeting the threshold for primary aldosteronism, but contributing to primary hypertension. So I always like to show this slide. And so this is taken from 4 large hypertension centers and looking at the distribution of 24-hour urinary aldosterone excretion. And so what you can see is even among untreated normotensive individuals, there's a large percentage of individuals that have 24-hour urine aldo levels that we would classify as primary aldosteronism, okay? And then when we get up into the resistant hypertension population, we're talking 1 in 4, or 1 in 5 reach the threshold for primary aldosteronism. But it's also important to remember is this is not a binary variable, okay? It's a spectrum, and you can see, what if you're right below that threshold or that line there, okay? Should we be treating you with a diuretic and an ARB up front? I would argue probably not, okay? They're going to respond almost as well to spironolactone, or better to something like spironolactone or a pleuronone than anything else. And why is that? Well, we know that autonomous aldosterone production suggests or produces what it results in is sodium reabsorption, okay, as well as potassium secretion, and then extracellular fluid volume expansion, ultimately hypertension, and then as well with that renin suppression. The best data that really reflects this is the Pathway 2 trial. So this was published almost a decade ago, looking at patients on the ACD combination and then randomizing them to spironolactone, doxazosin, or bisoprolol. As we all probably know, spironolactone was far superior in terms of blood pressure reduction than either of these medicines. But what is really important here is that on the x-axis is the distribution of renin levels, okay, when they check it. And as you would expect, sort of a normal shaped curve there. But what about at this lower end of renin, okay? So the ones with suppressed renin, probably a large percentage of those individuals with autonomous aldosterone production. Look how much blood pressure reduction we get with just a 25 to 50 milligram dose of spironolactone, okay? Tiny dose. You're getting 15 to 20 millimeters of mercury blood pressure reduction in that area. And to give you a little bit of a perspective, your average blood pressure medicine at an average dose, you're really more in the 7 to 9, okay? So we're talking, that's equivalent to 2 blood pressure medicines in this scenario. And so it's being cognizant of that. We know aldosterone plays a role. Now, granted, not all those individuals are strictly high aldo suppressed renin. Some would be low aldo, low renin, more of your little type phenomenon, little syndrome. But just something to keep in mind, because we definitely underuse MRAs. But why don't we just use them, okay? I think we should be using more than them. But why are people scared of them? Our heart failure colleagues are the only ones that are not scared of them. And it's because of their off-target actions, right? They have estrogen-like effects. We know that there is a risk of hyperkalemia, particularly in patients with lower GFRs. And those tend to be the ones with resistant hypertension. And then there's also this question of non-genomic effects of aldosterone, okay? And those are ones that are not caused by binding to the mineralocorticoid receptor. And I have to do some hand waving to say, yeah, that makes a difference. But we know that when we look at individuals with primary aldosteronism that get an adrenalectomy, okay, versus those that are treated with an MRA, so just blocking the receptor, those that actually get removal of that excess aldosterone do better, okay? They have less incidence of atrial fibrillation, less vascular stiffness, et cetera. So maybe there's something going on beyond just that receptor, that MRA receptor, okay? So this is what brings up a real sort of hot new class of medicines, which are called aldosterone synthase inhibitors. And I'll correct myself, it's not really that new a concept. Osilodrostat, or LCI 699, is an example, and that really stopped development about 10 to 15 years ago after a underwhelming phase 2 study, which had some issues with cortisol. But those issues appear to be resolved, and then there's multiple studies underway here. So I don't want to scare anyone with this slide here, but really looking at the endocrinology or the pathways associated with it, we know that aldosterone synthase inhibitors, theoretically, should inhibit the CYP11B2, okay? What plagued other medicines, like osilodrostat, was that they had off-target effects on CYP11B1. And that's not unexpected, okay? They are about 93 to 95% homologous in terms of what they look like. So you really have to have, when you're developing one of these drugs, you really want to target that CYP11B2 more than the CYP11B1. Otherwise, you're going to blunt cortisol synthesis. And actually, osilodrostat did such a good job at blunting cortisol production that it's now used for Cushing's. So it's just completely repurposed in this scenario. So really you want to get to that CYP11B2 in a specific way, and I'll talk about multiple drugs that have done that. And you don't have to take my word for it that these are a success story or an emerging success story, okay? We can look at a variety of things published even just last year, looking and talking about aldosterone synthase inhibitors. So Michelle Azizi from Europe published this in combination with the baxdrostat data, which we'll talk about, really talking about decreasing the effects of aldosterone in resistant hypertension. There was this editorial, Entering a New Era of Antihypertensive Therapy, talking about zilebesiran, which we talked about, as well as referencing aldosterone synthase inhibitors. And then Brian Williams from the UK talking about aldosterone as a therapeutic target in hypertension as well, and another potential success story, a new dawn, shall we say. So there's many of these under development. What I want to really highlight is the three with the most clinical data to really support their further study. There's a couple that are a little bit smaller. There's one with some preclinical data, and then one with a phase 2 trial just in primary aldosteronism. But let's focus on baxdrostat, lorundrostat, and then this this BI compound that was just published in the Lancet earlier, or late last year, excuse me. So baxdrostat, many of you probably saw this, published about a year ago, New England Journal of Medicine. The data was initially published at AHA, or presented, excuse me, AHA 2022. So they did a phase 2 study in uncontrolled patients, uncontrolled hypertension on 3+ medicines with a diuretic. It was 12-week double-blind, placebo-controlled. So there was a few different doses of baxdrostat or placebo, and primary endpoint was change in office systolic blood pressure at week 12. And so what you can see is actually a very robust placebo response, almost 10 millimeters of mercury. But in the 2 milligram daily dose of baxdrostat, you got 20 millimeter mercury reduction in blood pressure. So we're talking about an 11 millimeter of mercury total placebo subtracted change in systolic blood pressure, and about 5 diastolic in this scenario. That was pretty consistent over time. And then in the change between the 1 milligram dose was about 8 millimeters of mercury. So a dose response, and hit that about negative 10 compared with placebo, which is sort of the sweet spot for a lot of these new hypertension drugs. This was quite prominent, so much so that AstraZeneca paid almost $2 billion for them to buy them and work this up. And they are doing a phase 3, larger phase 3 of about 700 to 800 participants as well. Now, I will put the caveat on this, is that the second study, which is not nearly as well published, of baxdrostat, was actually a negative study, okay? And it probably has nothing to do with the medicine itself. It was the HALO study. It has to do with the placebo group getting a 15 millimeter of mercury, I think it was in that range, reduction in blood pressure. So that has to do with how we measure blood pressure appropriately, how we make sure that patients are actually adherent to the medicines before they actually get randomized in the trial. Otherwise, this number probably would have been about 3 to 4 billion if that hadn't had that failed study. So that's one potential option when we think about aldosterone synthase inhibitors, and to be determined. So baxdrostat looks promising. Now we'll talk about lorundrostat. And so their only data was published by us earlier this year, so September, in JAMA, looking at their phase 2 study data. And it was an 8-week double-blind placebo-controlled, and it was really a dose-finding trial, okay? There was 6 arms. There was placebo and different doses of lorundrostat, either daily or BID, okay? And the primary endpoint was change in office systolic blood pressure from baseline to week 8. And these individuals were a little different. They didn't have to be on 3 medicines. They had to be on 2 or more, okay? And not a specific standardized regimen or anything like that. And there was 2 specific cohorts, okay? Cohort 1, which was the majority of individuals, was in individuals with suppressed plasma renin. And if you remember back to what I talked about, that pathway 2 study, theoretically, those individuals are going to have a more robust blood pressure lowering response, okay? And so they were randomized, 1 to 1 to 1 to 1 to 1. And then cohort 2 was more of an exploratory cohort, okay? And it looked at only 37 participants, but these were individuals without suppressed plasma renin, okay? And they got the highest dose of lorundrostat, 100 milligrams daily, and were randomized 1 to 6. So what was the primary endpoint? So these were, again, those individuals with suppressed plasma renin. And so what we saw was placebo group got about a 4 millimeter mercury reduction, which is sort of in line with what we would normally see. And then I wouldn't necessarily classify it as a dose response, but what you can see is that placebo subtracted change with those 50 milligram daily dose got almost 10 millimeters of mercury. Okay, we're talking 9.6. And then it tends to even out right around 100 milligrams daily. So you can see that there. So again, in about that 10 millimeter mercury, placebo subtracted, what we're thinking about. Now, the other question becomes is, well, is there a difference in terms of blood pressure lowering between those two cohorts, 1 and 2? So suppressed plasma renin and non-suppressed plasma renin. And based on these data, the answer is no, okay? About 11 millimeter mercury reduction amongst those taking the highest dose, 100 milligrams daily, from a systolic blood pressure perspective in both cohort 1 and 2. So it probably doesn't make much of a difference. What I think was probably the most fascinating thing, all exploratory, of course, but pre-specified, was small numbers, but was really what was the impact of aldosterone synthase inhibitors, particularly lorundrostat, in individuals with obesity. And pretty profound difference between those that had the body mass index 25 to 30 compared to over 30, okay? We're talking almost threefold increase or decrease, additional decrease in blood pressure in the 100 milligram daily dose, and obviously almost 17 millimeters of mercury in the 50 milligram daily dose. And the thought process behind that is all those extra cells within the abdomen, that central adiposity that we talk about, they're secreting all kinds of hormones, and there's likely dysregulation of the renin-angiotensin-aldosterone system there, and likely to respond very well. And I think clinically, many of us who have treated those individuals with hypertension know you put them on a little bit of spironolactone, you put them on a little bit of eplerenone, people get a very robust blood pressure lowering response, particularly those that have body mass index 32, 33 or higher. So there's a variety of ongoing trials with lorundrostat that to be determined over the next year to two. Out of C5, we're participating and running the Advance HTN trial, which is uncontrolled hypertension in a standard background regimen. So those individuals are going to it's not all comers coming in and on 12.5 hydrochlorothiazide and 5 amlodipine? No. So patients are ultimately put on indapamide 2.5, amlodipine 10, and olmesartan 40, or just olmesartan 40 and indapamide. And then they get lorundrostat, either 50 milligrams or 100 milligrams daily. And so we'll see what that shows. And then their phase 3 study is ongoing, just started in uncontrolled, and that's really more of a safety trial as well. They want to see efficacy, but also safety. For the FDA, you need about 1,250 to 1,500 patients to actually to get approval for hypertension. Then finally, we have this compound, BI 690-517. This was not a blood pressure trial, so I'm not going to go into too much detail. It was in CKD, looking at aldosterone synthase inhibition in combination with an SGLT2 inhibitor, so empagliflozin. So they could have anywhere down to a GFR of 30, but they had to have an elevated urine albumin creatinine ratio and be taking an ACE or an ARB. I'm not going to, they reduced albuminuria, but I'll point to the blood pressure data that they suggested. You get about a 6 millimeter of mercury, so nothing to write home about. But again, these patients didn't have hypertension at baseline necessarily. So really, it doesn't look like they're going to develop it for a hypertension indication, but I guess we'll see. Okay, finally, what's going to be the first new blood pressure medicine approved by the FDA in more than a decade? Well, it's aprocitentan. Probably by the summer of this year, we'll see this available. This was, the phase 3 study was published in Lancet in 2022, presented at AHA 2022. It was a precision trial. It was a phase 3 study, enrolled about just over 700 patients. They were on 3 drugs, including a diuretic, and primary endpoint was change in office systolic blood pressure over a 4-week period. Now, there was 3 parts to this trial. I think it was elegant and nicely done. Part 1 was this double-blind, placebo-controlled, 2 doses of aprocitentan, which is a dual endothelin antagonist, or placebo. Part 2 was everyone got active drug, okay? And then Part 3 was the double-blind, placebo-controlled withdrawal. Okay, and so this is the trajectory, or at least the sort of course of the trial. And so what you can see on the far left of the figure there is that everyone starts out quite high. Okay, we're talking between 150 and 155 millimeters of mercury systolic. Then when you treat them, even with placebo, they get a huge blood pressure lowering response. And we see this, okay? People start taking their medicines when they're actually in a trial, okay? And so you see about a 4 to 5 millimeter mercury difference between aprocitentan and placebo. Then everyone essentially stays right around 135. And then there's this randomized withdrawal. Okay, so some people, double-blind withdrawal. So some people stay on aprocitentan 25. Some just go to placebo. And so when you look at that primary endpoint, which we have to do, okay, it only looks like about less than 4 millimeter mercury decrease in terms of blood pressure. But there was an 11 millimeter mercury decrease in the placebo group. So you got to be a little bit wary about that and say maybe the effect is actually more. And so that's why I turn your attention to the right side of that panel and say it's probably more in the 8 to 9 millimeter mercury range when you actually withdraw it. So to be determined. I think what's really probably the most worrisome thing about this drug is that it does induce fluid retention and edema. And so you'd have to, at least when I think about prescribing it, someone would have to be on a pretty decent dose of a diuretic. But some of the benefits of it is it doesn't change creatinine, okay? It doesn't change potassium, okay? It doesn't do any of that. So there may be a role in uncontrolled hypertension with advanced CKD. So we're talking stage 4, stage 5. That's a little bit to be determined. So finally, we cannot have new pharmacotherapies and device-based therapies, but we can't forget the basics, okay? I still tell my patients that hypertension management is 70% lifestyle, 30% medications. So if we're not watching our sodium, exercising, decreasing our alcohol intake, making sure we have enough potassium, we're not going to get where we need to go, okay? This is a modified version of all Class 1A recommendations of non-pharmacological therapies to lower blood pressure, and all our patients in prevention get a copy of this when we're treating them with hypertension. So how much blood pressure lowering you just get from going on a DASH diet, that's that second column there, almost 11 millimeters of mercury, okay? Low sodium, about 5 to 6, okay? Regular exercise, 6 to 7. So it's important to stress this as well. They have to go hand in hand. Otherwise, patients just keep accruing medicine after medicine as they get older. And you can see similar guidelines in the European, et cetera. I think the important thing that we really embrace in our preventive cardiology section, and hypertension community in general has embraced it too, is that management is a team sport, okay? We can't do it alone. Exercise physiologists, nurses, nurse practitioners, pharmacists, dietitians, they all play a role because blood pressure management is so multifactorial and it's so prevalent, okay? There are not enough cardiologists, endocrinologists, nephrologists, even primary care doctors to treat the epidemic that we have, not only in the US, but nationwide. So we have to involve those individuals, get patients back to be seen regularly. So doing those lifestyle things in combination with standard of care plus some of these newer drugs, hopefully we will gain better control over the silent killer, which is hypertension. So in conclusion, we know hypertension is complex. We do not do a good job at treating it in general, so we need to do better. New pharmacological therapies, I think, have great promise, and it's really a fascinating and fast-growing field, but the basics still matter in terms of lifestyle. So thank you very much.
Outstanding presentation, very well done. Questions from the audience, because this is a very important topic. Yes, Mo. There is one second, there is a little microphone so people can.
Every trial you showed significant reduction of blood pressure with placebo, and that's like from 5 to 10 to 11 to 13. Should all these new drugs be long-acting drugs, like one that you take for a week or two instead of taking it a day? Because I mean, that's at the population level, dropping blood pressure by 5 or 6 or 9. That's big.
Yeah. No, I completely agree. And that's why there's so much enthusiasm for the long-acting injection every 6 months like zilebesiran. That's why there's enthusiasm for renal denervation too, which, as you may know, was approved by the FDA in November. It's this always-on phenomenon, right? And we don't have to worry about people taking their drug every day because, yeah, we know patients don't take their blood pressure drugs. They don't feel it, right? And they don't want to take it for 20, 30, 40 years, which many patients have to or should be.
One question from me, Val, you have another question. So, when we talk about hypertension or hyperlipidemia or all these things, precision medicine is now the way to identify the patients, that which patients will benefit from what kind of therapy. I understand the guidelines that, we do this typical thing that we treat everybody similarly. What are the efforts ongoing for polygenic scores? What are the ways that people identify maybe with biomarkers to say that which patient should be treated with which medications first and which will be more precise way of treating hypertension?
Yeah, and so that study or that line of investigation has been going on for 30 years. When we look at the sort of the low renin phenomenon, and it never really bore out to any extent. There's a lot of enthusiasm about using artificial intelligence and to look at large electronic medical records and say, how are individuals getting better controlled? And we may not know necessarily why, but can we use machine learning to figure that out and choose the best therapy for them? I think the biggest thing from a personalized perspective is recently has been understanding the contribution of autonomous aldosterone production. And for a lot of patients, maybe using spironolactone as first line. And I'm not the only hypertension expert to advocate for that. There's been a lot of people sort of throwing that around over the past year or so.
Yes, Dr. Nissen.
Luke, so a Plerinone versus spironolactone. What does a Plerinone cost compared to spironolactone, and why isn't it used more frequently?
So really to get effective, well, it's not quite as good a blood pressure lowering drug. And if you really want to get full coverage, it should be a BID drug. So that makes a Plerinone a little bit more a shy away from it. It has less anti-androgenic effects, which is beneficial. A Plerinone isn't really that expensive with some of these newer, Amazon Pharmacy, Mark Cuban's Pharmacy, et cetera. You can get it for relatively inexpensive. So those are the major differences. Also, most people don't really know how to dose a Plerinone. They dose it similar to spironolactone. So you start at 25 once a day, but really it should be 25 BID to start and then work your way up.
So, you see a lot of patients with hypertension. What are the most common areas where you make a difference? Like when people send you patients with hypertension to treat, what are the most common, not mistakes, but what's most common ways that you can improve the hypertension therapy from your clinical practice?
4 things. Number 1, I talk about those lifestyle, or I give them the handout for the lifestyle, but I take 2 minutes and talk about sodium intake. And everyone says, yes, I've heard about low sodium, but I don't know. No one's given me a number, or no one's told me to count, or no one's told me that my piece of bread has 200 milligrams of sodium in it. So that's number 1. Number 2, switch them to a longer acting thiazide type diuretic, indapamide or chlorthalidone. Number 3, get them off of losartan, which is far and away the weakest ARB, and put them on something like telmisartan, irbesartan, et cetera. And then number 4, add spironolactone.
Very useful comments.
Luke, has there ever been allergic reaction to those siRNA against angiotensin?
No, I mean, you have your typical injection site reactions, but
No, but I'm talking about, people have severe angioedema and things like this, right, to ACE inhibitors.
Yeah.
And so has there ever been any type of an allergic reaction?
There has not, no.
Anything, question or any questions from the audience, online audience? No.
So with these longer acting medications, obviously sometimes when we're talking about monthly injections or medications that last for 6 months, we know that things happen, right? Patients get sick, they get COVID, or they have an operation to go to. Is there anything being looked into ways that you could, offset that effect or potentially reverse it or anything like that?
There is. They're not necessarily in published research at this point, but Alnylam, those groups, Roche, are looking at that with zilebesiran in terms of something to reverse it. Okay, but I think we get a little bit of at least, we're a little bit more comfortable based on some of the data that I showed where things like higher sodium intake, fluids, et cetera, may be able to attenuate this severe decrease in blood pressure potentially. But when you think about gene editing in this, right, these systems are here for a reason, right? And so they can get dysregulated. But what does happen when you run into trouble? And I think it's still to be determined. Is the benefit worth the potential risk? And that's why maybe a shorter acting, so once a month rather than once every 6 months, may be better. Theoretically, we'll see.
I think this is a very exciting area, and thank you for enlightening us with such a wonderful talk. So thank you again.
Great, thank you.